We begin, I want to introduce Dr. Mark Swain, who's a hepatologist at the University of Calgary, a passionate leader in MASH who has continued to lead the way in clinical care pathway development. And he's a global leader, a global opinion leader, and a longtime close friend of mine. And I appreciate how much he cares about his patients. Tonight, you will see firsthand what I mean because we had two presenters tonight who had unexpected last minute conflicts, and Mark graciously agreed to cover both Dr. Nuruddin's and Dr. Arcuri's presentation. So Dr. Swain is incredible, and I cannot thank him enough. Mark, over to you, and I really, really appreciate what you're doing tonight and that you could do this with us and for us. Thank you.
Thanks very much for that introduction, Mike. Of course, I'm happy to fill in the gaps and hopefully I can live up to their billing. I'm going to be using their slides, so I think it'll look quite similar to what they were going to give anyways. But on behalf of the Canadian MASLD network, I'd really like to thank everyone for attending. I think this meeting is outstanding, and it's a really exciting opportunity to exchange ideas and thoughts between primary care and frontline caregivers and specialist care. And I think it continues on with a lot of the things that Can Masled has really tried to advocate for. I'd like to introduce Rick Ward, who's going to be our moderator tonight. He's a community-based physician here in Calgary. I've known him for many years. He's also a medical director of Primary Care Alberta in the Calgary zone, and he has a long history of working very closely with different specialist groups in designing and co-designing and implementing clinical care pathways. And I've worked with Rick on a number when I was head of GI in Calgary, but subsequently as a hepatologist when we launched a number of pathways, including the NAFLD, now MASLD pathway in Calgary. So thanks very much for moderating tonight, Rick. It's really great to have you here.
Yeah, thanks so much, Mark, and thanks to the organizers, and also thanks to my colleagues across Canada who are joining. Really, the paradigm has shifted that where the early warning system and the first responders and the first identifiers of patients with chronic liver disease, and we have the ability to facilitate investigations and to change the natural course of this condition. So it's really cool to be a part of this. I'm going to bounce things back to Mark to sort of set the stage with definitions and talking about the role that primary care has to play in this. On a personal note, I'd just like to recognize the leadership that Mark has played in the Calgary zone in really bringing primary care together with the specialty care group to be able to look at this important disease area and to make a difference in patients' lives. Mark, back to you.
Thanks, Rick. I'm going to now share my screen. So obviously, I'm not Mason Nuruddin, but I'm going to be giving his talk today. I've actually known Mason for a long time. I met him probably over a decade ago when we were actually giving a talk overseas together. I'd never met him before, but we really hit it off. He's a great guy, and he's really a world leader in MASH, MASLD and MASH. And his talk and now my talk is really understanding MASLD and MASH and the relationship between primary care and the hepatologist. So I'm going to, there's three main objectives. One is to describe steatotic liver disease, or SLD, and metabolic dysfunction associated steatotic liver disease, or MASLD spectrums. And for many of you, MASLD, you'll be more familiar with NAFLD. That name has been changed to remove the fatty component and also the alcohol component. And I'll get into a little bit about why that was brought about. Really, the stigmatizing aspects of those things was a big driver behind the name switch. going to discuss the prevalence of MASLD and MASH in high-risk populations. And so these are the people that we need to be most concerned about, and discuss the need for multidisciplinary care, of course, the interaction between specialists and primary care in driving that multidisciplinary or really team approach to patient care to get the best outcomes in our patients. So when you are well, when people are talking about steatotic liver disease or SLD, they're really talking about a spectrum of diseases. And and this new nomenclature, so the old nomenclature, which was non-alcohol related fatty liver disease, it was really essentially that if people consumed alcohol, then they were really essentially eliminated from that definition. But whereas we all know that alcohol consumption is a spectrum, and so you go all the way from people that don't drink alcohol, and so they would fall into here on the far left, which is the pure sort of MASLD without an alcohol component. But this new definition allows you to actually also include people that have that consume alcohol, and so the spectrum goes from sort of modest levels of alcohol consumption. So we'll do it on a daily basis. So sort of 20 grams per day for a woman and to 30 grams a day for a man, all the way to 50 grams for a woman or 60 grams for a man. And just for your reference, I've just put this up here. This is sort of gives you an idea how much is in a gram. So 10 grams is sort of like a shot of alcohol. 15 grams would be a beer, and a pint of beer is almost 20, and a standard glass of wine about 20. So that kind of shows you where people are on that spectrum. Once you go beyond that, then you're really in alcohol-associated related liver disease, or ALD. But within the MASLD confines, you are allowed this spectrum of consumption. And we now are recognizing that people in this spectrum are actually a lot of the people that are overrepresented on the people that have progressive liver disease and end up with advanced fibrosis and cirrhosis. And then there's other cause of fatty liver disease or fat in the liver, and certain drugs like methotrexate, tamoxifen. There's a number of drugs that can do that. A number of other liver diseases can be associated with it, but we're really going to focus today on this this part on the left hand side. So the MASLD and then the MET-ALD. So MET-ALD is just MASLD with this alcohol consumption. And so when we're talking about MASLD spectrum, it's important, I think, at a primary care level to have an idea of when a specialist might be referring to a sort of a people who are at different risks of progressive liver disease. Of course, when someone has MASLD, which is metabolic associated steatotic liver, so this is not necessarily disease, this is just sort of fat within the liver cells. These people have significant metabolic dysfunction, but they don't have disease. But once they start to develop MASH, which is a metabolic dysfunction associated steatohepatitis, so that just means inflammation in the liver, then they're starting to have disease, and then they start to develop potentially scarring, and that scarring is graded on a scale of F1, which is mild, F2, which is moderate, F3, which is advanced, and then F4 is cirrhosis at the far right. And this when people look at a liver biopsy or talking about at-risk MASH, which is really the patients that we're most concerned about. Obviously, if someone's cirrhotic, that's a major concern. But the therapies that are coming around and where we can really, I think, make a huge inroad on reversing this disease is really by in these individuals who are at risk MASH or F2, F3. And how they grade that, or how they decide on that, is they on a biopsy or the equivalent of a biopsy if you're trying to use non-invasive markers. They look at a number of things. They look at the inflammation, which is the immune cells in the liver, and this blue stuff is scar tissue. They look at steatosis, which is these white sort of areas that are missing. That's fat within liver cell. And then this thing called ballooning, which is this big sort of blob here. And this is a liver cell that's dying. And ballooning is felt to be the specific feature on a liver biopsy, which points to people that are at the highest risk of progressive disease. And what the pathologists do is they look at the biopsy and they score the amount of fat from 1 to 3. They score the inflammation with regards to pockets of inflammation, score that 1 to 3, and they score the ballooning from 1 to 2. And so it's a score out of 8. So when people have at-risk MASH, they have F2 or F3 fibrosis, and they have a score on this thing of 4 out of 8. And so when you're also looking at anything that comes from a clinical trial on people they're actually looking at people with at-risk MASH who fill that criteria. Now, what about the prevalence of MASH worldwide? Well, if I had given this talk just a few years ago, it would have been closer to 25%, but now it's 30%. So it shows you how fast this is changing. And if so worldwide, about almost a third of the population worldwide has MASLD. There's some areas that have higher levels. Certainly Latin America, it's almost 50%, almost half the population. In the Middle East and Northern Africa, but 37%. But you can see that the prevalences are quite high, and there are some areas or pockets where it's very high. What about MASH? So this is MASLD now when you have this inflammatory component that's where you get inflammation with or without scarring. So the global prevalence of MASH is about 5%, so 1 in 20. And then again, as you'd expect, the areas that have the highest sort of MASLD levels also have the higher levels of MASH, where in Latin America, it's 7%, so almost 10% of the population. But you can see about 5% globally. So there are certain groups that are at risk, of course, of MASLD, and one of the key groups are people with type 2 diabetes. So people with type 2 diabetes are overrepresented amongst groups that have progressive and more aggressive MASH and MASLD. And so when you look at globally, and you look at the global prevalence of MASLD, and this is using a CAP score, which I'll talk a bit about later, but a CAP score is really an assessment of how much fat's in the liver, and it's done by a probe that assesses that can assess for that. And when you look at the prevalence of MASLD in people that have type 2 diabetes, it's about 2/3 of them. So 2/3 of people that have type 2 diabetes will have MASLD, and when you look at the changes in the global prevalence of MASLD amongst people with type 2 diabetes, it's changed quite dramatically. It's increased by 50% between 1990 and 2004 and 2016 to 2021. And you can also see on the map here that there's also a geographical distribution that's a little bit different around the world, but and some of this is related to access to CAP assessments. So when you look at a cohort, so this is MASLD obviously from the United States, so this is an American cohort, but I think it really reflects the same thing that you would see in Canada. If you have 100 middle-aged this happens to be Americans, and you look at them and you look at how many that are going to have NAFLD, or say MASLD, 38% of that cohort are going to have, so like a third of them are going to have MASLD, and 14% of them are going to have MASH, or that inflammatory component. So when you look at this and you sort of, this is the 38% here with MASLD and 14% of the whole population. But if you start to look at different groups, so if you look at Latino or Hispanic population, you can see that MASLD and MASH levels increase quite significantly. So about half the population has MASLD, and a quarter of them are going to have MASH. Then you look at people who have diabetes in this cohort, and just over 2/3 of them, so 70%, but 2/3 is a good number to remember, will have MASLD, and about a third of them have MASH. So you can see why type 2 diabetics are people that there's a key focus on, because these people have a significantly higher risk of having both MASLD and MASH. But if you take this population, so this is a female Hispanic individual with a BMI that's above 30 and who has diabetes, 92% have MASLD and 50% have MASH. So you can start to see that as we think about a personalized approach to this, there are some groups that are significantly overrepresented in groups that are going to be at risk of progressive disease, and MASH is the start of that. So what about the comorbidities associated with MASLD? I'm sure in primary care you're very well aware of these comorbidities, and these are often the things that might bring a patient into a clinic, or that you're following longitudinally to help manage these. But when you start to look at the comorbidities in this population, I don't think this will be a surprise to anyone, but it just highlights the metabolic burden that they have. About 82% are going to be living with obesity. Almost half will have type 2 diabetes. And if you add in pre-diabetes, it goes up to about 60% roughly. People with dyslipidemia, 3/4. High blood pressure, they're getting close to 2/3, almost 3/4. And then the whole metabolic syndrome, almost 3/4 of them. So multiple metabolic comorbidities. Now, when you look at individuals, obviously people who have significant metabolic comorbidities are going to be at risk of mortality just because of these other comorbidities. However, when you look at liver-related outcomes, so this was one of the first studies that highlighted this one on the left, that it's actually the scarring in the liver which really drives severe liver disease endpoints. And the severe liver disease in this study was classified as liver decompensation or liver cancer. And what you can see is that there's maybe a slight inflection point when people are in the moderate scar range, so F2 out of 4. F3 is advanced scar. You can see it starting to turn up. And certainly when they have F4, their hazard ratio of developing a severe endpoint from a liver cause increases dramatically. And there was a study that suggested that in people that have F3 fibrosis, in 2 years, about 20% of them will have F4. And if you wait another 2 years, 20% of these people with cirrhosis are going to decompensate. So this is the groups that we're most worried about. And then if you look at liver-related mortality ratio, so that this is actually a meta-analysis and a systematic review. What you can see is when you started to look at the liver-related mortality, it really starts to climb. It goes up when you have moderate fibrosis, but when you get into these more advanced stages, and certainly cirrhosis, these are the people that are dying from liver-related causes. And when you look at in the States, it's the same in Canada. And this is the people who are listed and who receive a liver transplant. So what you can see if you look at both men and women, that the hepatitis C has declined and has continued to decline because we have such effective treatments for curing hepatitis C now. And if you look at alcohol related, and men it's going up, but women are too. They're just lagging. But certainly it's becoming a major driver of liver transplant in the States and in Canada. But if you look in the red here, this is NASH or MASH. And you can see that for men, it's increasing and really paralleling, and almost the rise is even steeper than alcohol. But if you look at women, it's taken over as the #1 indication for liver transplantation in the States. Now, so obviously there's a Games of Thrones analogy, but because it's such a prevalent issue, when you look in the United States, 95 million people are likely living with MASLD. If you look in Canada, say take 1/10 of that, 9.5 million, and in the States, there's 7,500 providers that provide hepatology specialist care. Well, of course, in Canada, that number would be significantly smaller, much smaller than 1 in 10 of that. And actually, we modeled what the world might look like from a MASLD point of view in Canada by the year 2030. And this is really based on changing prevalences of obesity in Canada. And when you start to look at, these are just the numbers that you're going to sort of potentially dealing with it by the year 2030. So people with moderate liver fibrosis, about 700,000. People with advanced liver fibrosis, so pre-cirrhosis, about 350,000. people with cirrhosis about 200,000, and people with decompensation liver cancer require a liver transplant about 25,000. So the numbers are quite staggering when you look at them like this. And for a country like Canada, that's going to be a major impact on our healthcare system. So this is a guideline for sort of assessing patients at a primary care level and at a specialist level. So if you look up here at the top, so the concept is to look at a population that's going to have a low prevalence of significant scarring, which would be in a general primary care practice. And so the goal is actually to exclude people that have a low risk of significant liver scarring, so they don't need to go and see a specialist or be assessed further. And then the people that are at risk, it gives a pathway to refer them on to a specialist assessment and potentially care. And most pathways, I'll come back to this later, are using what's called FIB-4. And a FIB-4 greater than 1.3 is sort of the cutoff that people use. If it's less than 1.3, then the current recommendation is these people do not need to be referred to specialist care and have their FIB-4 repeated every 1 to 2 years. If they're type 2 diabetic or have pre-diabetes, and they have greater than or equal to 2 metabolic risk factors, and do it a little bit less frequently every 2 to 3 years if they don't have diabetes or they have less than 2 metabolic risk factors. And obviously, you have in primary care, which is what you would be doing anyways. You're dealing with the cardio metabolic risk reduction, assessing for alcohol intake, and then lifestyle management, which is exercise and reduction in caloric intake. If they do have a number that's above 1.3, then if it's above 2.67, then the current recommendations are avoid even doing a secondary test. These are people you should consider referring for an assessment by a hepatologist or someone who's interested in liver disease, a gastroenterologist or general internal medicine. And if you have access to secondary risk assessment in Alberta, we're very fortunate. We have shear-wave elastography, which is at a community radiology level. But if you have access to a FibroScan, then it would be, if it's less than 8, then they're considered to be low risk. They come back into this pathway. If they're between 8 and 12, then or greater than 12, these are people that should be referred on. So 8 is kind of this magic cutoff number for FibroScan or shear-wave results. When they come to hepatology, then a number of places still are doing liver biopsies, but they'll get a FibroScan here. They'll be reassessed and they'll be fully assessed from a hepatology point of view. Might require other type of imaging modalities or a liver biopsy, as I mentioned, and then there'll be an assessment on whether or not they have cirrhosis, advanced scarring, or if they actually have low amount of fibrosis. So just to finish up here, what are the goals of MASH management? Well, the goals are what is happening already on a daily basis in primary care. I mean, obviously, with populations that are getting close to at least a third of the population that have MASLD, which and many of them have metabolic syndrome, then targeting that through weight loss, and there's a lot of options now that are entering the market with regards to approaches for weight loss that are both pharmacological and non-pharmacological. Managing their type 2 diabetes as best as possible. Managing their hypertension and their dyslipidemia to decrease their risk of having both liver and non-liver related adverse outcomes. And then there's liver-directed treatments. So the goals of treatment are really about MASH resolution. So weight reduction. Once you get to be about 7 to 10% of weight loss, then you're starting to see improvement in the inflammatory component. When you get about 10%, you'll start to see improvement in the scarring point of view. So weight loss on its own right, whether it's pharmacologically driven or non-pharmacologically driven, can improve both MASH and the scarring that's associated with it and regress the fibrosis. This will lead to reduction in liver stiffness and mobilize fat out of the liver, and it'll improve the biomarkers that we'll talk more about later. And ultimately, it's to improve major outcomes, ones that are liver related, which now are called major adverse liver outcomes, or MALO, or MACE, which I'm sure you've heard quite commonly, which are major adverse cardiac events. And there's growing interest in how these interact with each other with a number of the pharmacological treatments that are now available to treat obesity. And I'm happy to take any questions that you might have.
Thanks very much, Mark, and just invite our participants to enter any questions that they may have into the chat line, and we'll be able to address them. And before we bring on Dr. Kim, I'll maybe start off with one quick question. I noticed in your comorbidities, obesity was sort of at the top of the list in terms of comorbid conditions. But of course, all the other conditions have a high comorbidity with obesity, hypertension,
Yeah.
dyslipidemia, type 2 diabetes. So it raises the question, is obesity really at the center of all of this, or in those rare patients with hypertension or dyslipidemia or diabetes that are non-obese, is there something about those conditions which also predispose to fatty liver disease?
Yeah, that's a great question. So, I mean, obviously, obesity is a key driver of MASLD. However, there are places in the world where obesity, as in if we define it by what we might in Canada describe as a classical BMI risk, they don't fit that. And this is what we and so these are individuals that we call lean MASLD and even though the cutoff say and you'll see these in places like Southeast Asia and in India, all through that part of the world, I don't think people fully understand why. There's a lot of interest in diet drivers. Maybe rice as a major staple, and diet might be a driver. I don't think people really understand it, but what it's a reflection of is their metabolic health. They have significant issues with their metabolic health, and the way I always talk to patients is, whether it's someone who is dealing with being overweight or living with obesity, or they're not, it's really when I have say an ultrasound which shows fat in their liver, I know that their metabolic health is compromised, and I can talk to them about metabolic health and as a driver, and I can talk to them about how diet can impact that, and also whether they're diabetic or not, because of course a significant portion are not diabetic. That there's a number of things that can be done to help that. I guess the
Good.
other thing I'll just touch on is that if someone has fatty liver and they're not a diabetic and you follow them for 5 years, they have a 20% chance of being a diabetic in 5 years. So I also use that when I'm talking to patients because that's a motivator for a lot of people. They don't want to get diabetes.
Yeah, so fatty liver could be the canary in the coal mine for
Right.
vascular
I
or
think, yeah,
metabolic
yeah,
risks
yeah.
down the road. Listen, before we bring on James, question from Dr. Sharma. Can you talk about the liver fast test, which is something I'm not aware of?
Yeah, so so there are a number of different tests that people have developed to try to assess people for a higher risk of having MASH, right? And so the FAST test is one of them. There are a number of other ones. I really I didn't dive into that, and I won't dive into it much more. And the reason why is because um, most of pathways that we use to drive decision making about to refer or not to refer, I think we want to be homogeneous and we want them to be easy. And I think the nice thing about a FIB4 is it's a homogeneous thing. It's being recommended by many different groups, not just primary care, not just hepatology, but endocrinology and other groups. It's a relatively simple test to do, and there are now calculators available, and it's being incorporated into EMRs. And so, what I typically do is rather than go down the list of tests that are available and useful, I think the FAST test is really mainly used for identifying people for clinical studies. I think its utility at a primary care level for screening probably not that great.
Thanks to Dr. Yamamoto. And a second question about genetic testing. I'm just going to parking lot that because I have a feeling that answers to those may be forthcoming in the next session. I'm anxious to bring James Kim in, so I'm going to parking lot those, but guaranteed that we'll address them. Gives me the opportunity to introduce my friend and colleague, Dr. James Kim, who works down the road from me here in Calgary. He's an associate professor of family medicine at the University of Calgary. He's got a special interest in MASLD and chronic migraine, and he's a master educator as well. He's worked with the Diabetes Canada, and specifically was one of the co-editors for the Canadian Primary Care Today, and the leader author, I should say, of the MASLD guidelines in adults as part of Diabetes Canada's clinical practice guidelines. Again, just an all-star family doc and a friend. James Kim, welcome, my friend.
Thank you very much. So, um, thank you. Okay, um, so thank you for the kind introduction. It's always amazing to learn from you, Rick. And I've been looking up to you and learning from you since the day I arrived in Canada. So it's a great privilege to be here. So thank you so much for everyone. I was under the impression that Dr. Al-Khoury was going to do a presentation. Unfortunately, he's not here. Dr. Swain was going to participate. So let's see.
Would you want me to give this talk, James? I'm
So
happy
I
to give it.
actually made
Yeah.
a little part at the end that's the
Yeah.
part that I would do
Yeah, sure.
presentation on it. Yeah.
Okay. Well, I'm happy. Do I have control of this? I'm just going to see. No. You know what? I'm just wondering if the control could be switched so I can do this or I can just James, I'll just say next slide. Can I do that too?
Oh, here, next slide.
I can do it.
You can tell me next slide, Mark. It's me and Manjulika running the slides right now.
Okay, hang on. It's not working here yet.
I have control of the slides, so you can.
Oh, okay. All right. Okay. Next slide. So hang on. So essentially, what James and I are going to do here, we're going to try to create, at least virtually in everyone's mind, a primary care toolbox, essentially, and so approaches that you can use in your day-to-day practice. I think the key for all of these is to have a comfort to think of the liver side of metabolic syndrome, and then have a comfort on a way to evaluate your patients. Okay, so our key goals are how are we going to integrate liver health into patient visits? I think this is going to become increasingly important of recognizing the people who are at risk, and that from a liver point of view, obviously, people who have metabolic syndrome or metabolic comorbidities are at risk of other issues that need to be addressed. But this is focusing on the liver part. The screening process that you can approaches that you can use in your practice. So non-invasive tests like a FIB4 like we talked about. I'm not going to mention the FAST, but it would fall into this sort of a thing. Transient elastography, ultrasound techniques, ELF, and there was a mention earlier about ELF, but we'll come back to that. There was a question about that, and other blood biomarkers, how and when to use them, and if we can use them. Some of them are not available, and then workflow tips for primary care, optimizing efficiency and improving care. Next slide, please. So this is a patient that I'm sure would be relatively typical for in primary care. It's a 59-year-old female. She has type 2 diabetes. She happens to be Hispanic, and she's had diabetes for the last 12 years. She was a pre-diabetic for about 4 years before that. She has dyslipidemia, and she's living with obesity, and she comes into your office for one of her routine follow-ups. When you look at her labs, you see the following: that her ALT is 41, her AST is 39, and her platelet counts are 185,000. So there are no red signs. These are all within the normal ranges within your lab, or at least the standard normal ranges. Next slide. And so, how do you adapt? Go back, please. Yeah. So so when you have this patient in your clinic, so how do you identify their risk essentially? Who's at risk of from a liver point of view? So if they have two or more metabolic risk factors, if they have type 2 diabetes, as we just mentioned, and if they have steatosis on imaging, which of course highlights the fact they have significant systemic metabolic dysfunction, and they have elevated aminotransferases. So how do I use non-invasive testing to assess a person like this? Next slide. So there's a number of tests. So if you look on the left-hand side, we'll start off with the simple scores that are serological, and much of the focus that's going on now is on simple tests. And the most widely used simple test is the FIB4 index, really. AST ALT ratio, you can do APRI. People use these, but the FIB4 index is what most of the sort of algorithmic approaches within primary care to try to identify people who are at risk, and really even more importantly to make sure that people that are not at increased risk are not referred on. And then there are a number of proprietary scores. ELF was mentioned in a question. Here's the fast here. These are patients have to pay for these. Some are available, some aren't. ELF is available if patients are willing to pay. I think it's about $125 in Canada. In Alberta, I think that's the cost. And so a lot of patients are not super keen on paying that, but it can be used. And I'll talk about later how you can use that in the algorithm. Oh, please go back. Thanks. And then the other ones that you can use are imaging ones. So elastography, you can use FibroScan, as we'll talk about. ARFI is sort of a derivative of shear wave elastography. Broadly, I think certainly in Calgary, we find shear wave elastography. First of all, it's more widely available, and secondly, I think it's more accurate in the hands of our group. And then there's a number of ones that are being developed, like Velacure and Hepatoscope. They're not available in Canada. And then MRE, we used to be able to get it in Calgary and probably get it within about 4 to 6 months. Now I think they're over a year that they're booking to get them. So the demand is increasing, but supply is not. Next slide, please. So this is the FIB4 thing. Basically, what the part on the left is just to highlight is what it looks at. It looks at age, it looks at AST, ALT, and platelet count, and that's what it uses to calculate the score. And so obviously okay, so there's someone, they're saying, Dr. Sharma is saying that the slides are all black. You know what I'm going to do? James, can you just this, okay? Can everyone see the slides now?
We can see them.
Okay.
So
if anyone can't see them, please put it in the chat. All right. So I'll just, okay, perfect, good. All right. So age, AST, platelet count, and ALT values, and so you can see, because age is up on the top, that as the higher you go in age, there's always a concern that the FIB4 is overrepresented or too high. So people use different cutoff for people above the age of 65. Sometimes they use a higher cutoff, which I'll talk a bit about. But obviously, as the AST goes higher, and when people get more advanced fibrosis in fatty liver disease or MASLD, what they get is the ALT to AST ratio. The AST goes higher, so these get closer to 1 to 1. Normally, the ALT is about 2 to 1 to AST, and the platelet count goes down. And people who have a higher age are at more risk of advanced disease because they've had the condition for longer. So that sort of explains how that all works out. But basically here, when you look at the cutoff, low probability, this 1.3 cutoff is really used to rule out people that have at-risk MASLD. And I think the FIB4 is quite useful in that regard. If they're less than 1.3, then I think you can be comfortable in primary care to keep these people in your in their primary care medical home, and you don't, as long as you're following them sequentially as we talked about before, and doing it every 1 to 3 years, depending on their risk factors, then you're going to pick up people that progress above 1.3. And then if people are above 2.67, it doesn't mean that everyone here is going to have advanced liver disease or at risk MASLD, but their risk is high, and these are people that you really have to consider referring on. So this is the ELF test. I'm going to talk about it because you're going to see it in guidelines, and maybe at some point it might become more broadly available in Canada and covered by provincial health plans. But patients might come in and ask for it, or they might hear about it on if they Google or whatever. Essentially, what it does is it looks at everyone used to believe that fibrosis in the liver was permanent. So they were very interested in scar tissue deposition. So it was being laid down within the liver, and these are two markers of scar tissue being produced and laid down in the liver. So procollagen 3 and hyaluronic acid. However, we now know that scarring in the liver is a dynamic process. And so there's actually, if you give the liver a chance, it's constantly trying to pull that scar tissue back out and remodel the liver to get rid of the scar tissue. And so this is called repair. And so this is a molecule, this TIMP1, which actually blocks that process. So it blocks fibrinolysis, which is the breakdown of scar tissue. And so by definition, it increases fibrosis. So these markers all put together make the ELF score. They test them. It's proprietary, so you send the sample away, and it comes back. And really, the cutoff is 9 point. When people start to look at risk levels from ELF, ELF has some nice predictive qualities in that as you go higher, like above 11.3, these are people that actually are at increased risk of liver decompensation, so starting to develop liver failure. Above 9.8, these are people that have a high risk of advanced fibrosis. So this test can be used instead of like a FibroScan or shear-wave elastography as a secondary test after you've done a FIB4. So again, this was Naeem was going to give this talk. So these are US-based radiological tests. So I'll just mention, like, the one on the left is available here, but the other ones are not broadly available. Velicure is not available at all. ARFI is available in some places, but this is the transient elastography is really essentially the FibroScan. This is a FibroScan type picture, and it can be performed in a clinic with real-time results. The problem is that as people as they get more subcutaneous fat and they get a larger abdominal girth, especially people living with obesity, the failure rate becomes higher, or then the reliability gets less. There is an XL probe, which is better. However, as people get bigger and bigger, certainly above BMIs above 35 and 40, then the accuracy really is somewhat problematic. And it's an expensive device. These devices are not in standard radiology practices, and they're really in specialist practices. This Velicure, I'm not going to talk about because we really can't, it's not available here. But ARFI is sort of a concept similar to shear-wave elastography. And so essentially it puts ARFI actually looks at a spot. This is identified a spot here, and it does liver stiffness in that spot. And you can move around to different spots. Again, it has increased failure rates in obesity and the cutoff values. We have radiologists who routinely do ARFI in our center here, but I don't find them as useful as actually even getting a shear-wave elastography, which looks at more of a whole. It's more like a FibroScan, which looks at a wave that goes as shear wave that goes through the whole liver. This is kind of a cool simulation because this shows you what they're actually looking at when they do liver stiffness. So this is a FibroScan. So in a healthy liver, what the FibroScan does, it creates this shear wave, so an ultrasound type shear wave, and in a normal liver, it moves relatively slowly. And that gives this type of curve, which is a low stiffness. Whereas in a scarred liver, where there's more fibrosis, more stiffness, the wave goes faster. So this is why it does this. And so this is really what it's measuring, how the speed that this propagates through the liver, and then it gives a reading from sort of a six. Less than six is sort of normalish. Most normal would be 4 or 5, all the way up to 75, which is maximum. A FibroScan can also do something else. It gives something called a cap reading, which is basically it looks at how this wave attenuates or is blunted essentially as it goes through the liver. So when there's fat in the liver, it blunts it. So it's called a high attenuation whatever. It squishes and blunts this, and so this gives a cap value that's high. And the higher the cap value, so sort of 220, 230 is kind of normal. Once you get up to 250, you're starting to look at steatosis. 270 is often a 275 cutoffs that are used for moderate steatosis. Then as you get to 300 above, you're looking at quite severe steatosis. And a low cap value is no steatosis. So this is the breakdown that people, if a patient gets a FibroScan, they'll give a cap reading, and the cap reading will come out as an individual reading. So again, anything above 250 is steatotic liver, and the higher that value goes, closer to 400, which is the maximum, the more fat there is in the liver. And then the cutoff that we use is 8 kilopascals. So anything above 8, you're looking at people that are at risk. It doesn't mean they have F2 fibrosis, but they're at risk. And in fact, if you're in states prescribing new pharmacotherapies to treat MASH, 8 to sort of 15 is the group of people that you're looking at that are widely accepted as treatment candidates, and then 15 to sort of 19.9. You have to rule out cirrhosis, but these are the kind of numbers. 8 to 15 are where people are treating quite routinely in the state. So how do I risk stratify a patient that's in my clinic using non-invasive testing? Well, this is names sort of process which I think most hepatologists follow. So first of all, this is in primary care, is to identify patients at risk. So 2 or more metabolic risk factors, type 2 diabetes, and steatosis on any imaging modality, which tells you that they have significant metabolic dysfunction and elevated aminotransferases. Do they have a history of excessive alcohol consumption? Recognizing that the spectrum now with MASLD includes people that have moderate alcohol consumption are still included as MASLD. There just would be, as it gets more, they're MET-ALD. And then doing a CBC, because that gives you a platelet count, and then liver function tests and liver transaminase, so AST, ALT, platelet count and age, you're going to need to calculate a FIB4. And then using the FIB4 as the primary screening test in primary care to say, is this person at low risk, which is a FIB4 less than 1.3? Are they at intermediate risk, so 1.3 to 2.67? And these people require a secondary test, and that might be a liver stiffness measurement with a FibroScan, but it might very well be a ELF if the patient is happy to pay that fee or whatever. But that's also a useful test. And then there are people that have a FIB4 above 2.67, and those are high risk, and they really don't need to have that secondary test. They should just be, well, the consideration should be given to send them on to have further assessment by a liver specialist. The sort of equivalent liver stiffness measurements are if a liver stiffness measurement is less than 8, whether it's a shear wave or done by a FibroScan, those are low risk patients. and they can be followed along in primary care. If it's from 8 to 12, they're intermediate, and these are where hepatologists will do other tests. They might even consider a liver biopsy in those people. And then if it's above 12, then those are people that are significant probability of having at least F2 fibrosis. Doesn't mean they do, but they have a significant probability of